Hello, and welcome to the 11:45 session. I think we're going to go ahead and get started. My name is Sarah Wise. I am from the U.S., from Emory University in Atlanta, and I'm very, very honored to have the invitation from Alexander and Liliana to come and talk today. And I'm very excited to have this session on rhinitis and rhinosinusitis. And I will go ahead and start us off with my talk on the highlights from the International Consensus on Allergy and Rhinology, Allergic Rhinitis, what we know and what we don't. So, as we undertook this document, we wanted to ask ourselves this question, this primary question. What is the current state of evidence in allergic rhinitis? What do we know, what don't we know, and how can we improve things for the future care of our patients? Ultimately, over the course of about 18 months, we produced the International Consensus Statement on Allergy and Rhinology, Allergic Rhinitis, and you can see the title page here as well as the reference. The document is available for a free download from this website if you do not have it already and would like to take a quick photo. I'll have that later as well. Some quick statistics about the document. It took us about 18 months to prepare. It's a large reference document of nearly 250 pages. We had 107 multidisciplinary authors, including otolaryngology, allergy and immunology, pediatrics, pulmonary, and various others. We covered 8 broad content areas and 103 individual allergic rhinitis topics. And one benefit of this document, because it's so large, is it has a PDF on the table of contents has electronic links to each topic, so you can truly use it as a reference document to navigate to each of these topics. There is also an executive summary, which is available as well as a free download, and that's a much shorter summary of the document in full. These are the large sections that we covered in the ICAR document, everything from definition of allergic rhinitis and differential diagnosis to pathophysiology, epidemiology, diagnosis, management, and then conditions that are associated with allergic rhinitis. It's important to understand the methods involved in producing this document and exactly what it is. It's really a critical summary of the existing allergic rhinitis literature. It is not a meta-analysis. There was no additional analyses, statistical analyses done to produce the document, but it is considered a resource for evidence-based recommendations, as well as to allow us to understand the knowledge gaps within the areas of allergic rhinitis. We followed the evidence-based review with recommendations process that was developed by Luke Rudnick and Tim Smith, which includes systematic review of existing meta-analyses and high-quality evidence, a structured literature table for each of these reviews, ultimately an aggregate grade of evidence, and then a stepwise iterative review process to ensure that the evidence that we were capturing was high quality and that we came to a consensus on our recommendations. So this is an example of one of the evidence summary tables, and you can see that in a very quick line item, each study is placed into the summary table. It tells you what type of study it is, what the level of evidence is, what the conclusions of the study were, and what their endpoints were. Once those evidence summary tables are created, we then take all of that evidence together and arrive at an aggregate grade of evidence. And this is really what most people end up quoting when they discuss these documents. So is the evidence high level, A or B, or lower level, closer to the expert opinion arena of C or D? Once the aggregate grade of evidence is determined, we then consider things like benefit or harm of that individual management option and come to a recommendation for that particular treatment. There, at the end of each section is a literature summary that ultimately summarizes the aggregate grade of evidence, the benefit, harm, and cost of that intervention, and then has some additional statements, including the policy level, which is the actual recommendation level. You all may be familiar with some of the existing evidence-based reviews with recommendations that have been published in the ICAR journal. These are just a handful that are listed here. They're incredibly helpful for us to understand the current level of evidence in various chronic rhinosinusitis and allergic rhinitis disease processes. So as I said, the ICAR sort of process includes the evidence-based review with recommendation methodology and takes that methodology applied to each individual section or subject matter and collates it into a large document. This was first done by Richard Orlandi in 2016, where he examined rhinosinusitis. As I mentioned, we published the Allergic Rhinitis document approximately a year ago in February of 2018, and then coming soon is the ICAR skull-based document. That is slated for publication, I believe, in the summer of this year. So it's important that we remember that the recommendations in the ICAR document should be interpreted based on their strength of evidence. They don't necessarily define standard of care or medical necessity. We still have to evaluate our patients individually and determine the treatments that are right for each individual patient. So as I said, we learned from the ICAR process what is the current state of evidence, what do we know, what don't we know, and what are the current gaps and areas for future research. And I'm going to kind of review some of these, as well as some perhaps more exciting potential future developments in the treatment of allergic rhinitis. So some things we know well. Antihistamines work well for the treatment of allergic rhinitis. Both oral and intranasal antihistamines had very high levels of evidence, level 1A and 1B respectively. They work well for the treatment of allergic rhinitis and carried a strong recommendation for oral antihistamines and a recommendation for intranasal antihistamines. We also know that intranasal corticosteroids work extraordinarily well. In fact, if you were to choose one medication for the patient with nasal symptoms of allergic rhinitis, intranasal corticosteroids would be that medication. We also know that if we're going to add a medication to perhaps someone on an oral antihistamine, intranasal corticosteroids is really the choice to add for the patient with nasal symptoms of allergic rhinitis. Other therapies that have very strong levels of evidence, nasal saline, the combination of intranasal corticosteroids and intranasal antihistamines, and then subcutaneous and sublingual immunotherapy. These all carry level of evidence at A, meaning that there's several randomized controlled trials, systematic reviews, and meta-analyses to support their use. What are some of the things that have weaker levels of evidence for allergic rhinitis? When we typically think of allergic rhinitis, we think of kind of a three-pronged or tripartite treatment option. And I've discussed a couple of the pharmacotherapy options that have very high levels of evidence, as well as a couple of immunotherapy options that have high levels of evidence. The other aspect of allergic rhinitis treatment are things like environmental controls or allergen avoidance. And interestingly, these have many of these have weaker levels of evidence. So when we look at the various environmental control measures for the treatment of allergic rhinitis, for house dust mite, cockroach, pet dander, pollen or occupational allergens, the interesting thing about these studies is that they often measure the actual allergen levels. And while some of the environmental control measures that we put into place can reduce the levels of antigen, a lot of the studies don't actually measure respiratory outcomes in these patients. So they're not actually measuring symptom control. And that's really what's important when we're treating our allergic rhinitis patients, is to know if their symptoms are controlled. So The benefits, we can reduce environmental antigen exposure and possibly reduce symptoms, although the evidence is weaker in that respect and really needs some more work. What are the new developments? What are the things that people are talking about? What are some potentially exciting future interventions for allergic rhinitis? So one of the things that's caught my eye is something called intralymphatic immunotherapy. This is something that we may not be as familiar with as otolaryngologists because it actually involves allergen injected directly into the inguinal lymph nodes, which is usually a place that we're not going as otolaryngologists. But what this involves is 3 injections of allergen, each given at 1-month intervals. So it's a total treatment of approximately 3 months. And the early studies have shown that this can provide symptom benefit and good control for our allergic rhinitis patients. It reduces office visits. Less allergen is needed because it's actually injected directly into the site of action, and it has lower risk of adverse events. Overall, there have been several randomized trials, although the number of patients really still needs to be improved. There have been less than about 300 patients included in these trials altogether, and several of the trials were performed at one institution. So we really need some multi-institutional studies with controlled studies, larger numbers of subjects, and this needs to be compared to subcutaneous and sublingual immunotherapy. But I personally think that this is an interesting and exciting potential future avenue of treatment. Local allergic rhinitis. This is basically where IgE is produced locally in the nasal tissues and causes symptoms of allergic rhinitis, but the specific IgE is not detected systemically. This has been studied most prevalently in Spain. In the US, unfortunately, we don't really have commercial tests available to evaluate for local allergic rhinitis. And so we really need some more evidence kind of looking at the availability of testing and treatment for our patients in the mainstream. We also need to understand how to collect, how to normalize the data, and really how to kind of apply this to our widespread patient population. What are some of the things that we don't really talk about much, but perhaps we should? Maybe acupuncture for allergic rhinitis. So this is really a traditional a non-traditional alternative therapy that some of our patients are potentially interested in, but has not really been widespread. There have been a couple of meta-analyses to look at this. So an early one that included 7 studies compared acupuncture to sham acupuncture, which is basically inserting needles into sites that are not specifically directed at the adjustment of the qi. And the initial meta-analysis basically did not show significant benefit, but a subsequent meta-analysis, including 13 studies, did. So overall, this particular treatment, the use of acupuncture, is considered a potential option for allergic rhinitis patients. And then probiotics. This is interesting. The US probiotic market is very, very prevalent. It was estimated that about $3.3 billion were spent on probiotics in 2015. So we considered this as an option for allergic rhinitis patients, largely because the probiotics that are studied are highly varied. There is not one specific probiotic product that was studied. And so while some benefits can be shown, we really need more studies to show the individual probiotic benefit. The other things that can potentially be considered knowledge gaps, these are just a few of them. Things like risk factors for allergic rhinitis, really better understanding genetics and the effect of global warming on allergic rhinitis. better understanding some of the newer diagnostic tests, things like the basophil activation test, commercialization of nasal-specific IgE, and then also better understanding some of our skin testing methods, like the use of a single intradermal test after a negative prick test. And then finally, as we strive to best understand treatments for allergic rhinitis, economic comparisons of various immunotherapy modalities would also be beneficial. So I think it's really important for us to understand guidelines and consensus statements and how we can use those to help treat our individual patients. The ICAR document has several recommendations in it, but it's also really important that we use our minds and our knowledge as individual clinicians to really specify the treatment for each individual patient as best we can.